Hello, everybody. I'd like to welcome you to the launch of the European Institute for Women's Health, Maternal Health in the EU report. And I'm delighted with such a broad range of relevant stakeholders participating here today. In fact, I'm reminded of the words of the EIWH Office of Research on Women's Health in 2010, which said, the health of women has a direct bearing on the health of the future generation, their families, communities, and ultimately the health of society. So how true is that? And maternal and child health is a vital point for public health intervention. The protection of mother and child is of paramount importance to society, and every woman has a fundamental right to high quality maternity care. So it's vital that every woman in the EU receives the same care that she and her family require during this important time in their lives, wherever they live. So today we'll first hear about the findings of the Maternal Health in the European Union report, and then we'll hear from our panel of relevant experts in the field who'll address issues such as vaccination, mental health, gestational diabetes, access to appropriate care for diverse populations and diverse range of women. So we've brought together representatives from the European Commission, European Midwives Association, International Gender Medicine, European Medicines Agency, the Conception Project, and the Irish Health Department. So in 2018, I was delighted to support the European Institute of Women's Health, Healthy Women, Healthy Europe campaign. And so I'm really pleased again to be part of the progress towards achieving a healthy state for women across Europe. So mental health, maternal health and access to high quality care is essential, especially for women in our marginalised communities. Currently, many women experience complications during pregnancy and childbirth that can cause severe maternal morbidity. And some of these morbidities are caused due to cardiovascular diseases, hemorrhages, high blood pressure, can result in seizures, strokes, blood clots, and infection. So a report such as we have today is really important to highlight these type of issues. In 2007, more than 290,000 women died worldwide due to causes related to pregnancy or in childbirth, and many deaths are preventable. But aiming to reduce maternal morbidity and mortality is just not enough. We need to strive for the promotion of a comprehensive health and well-being of both mother and child. And today, healthcare must shift to a citizen and patient-focused healthcare view with equitable access to high-quality healthcare for all of us. So it's been gender equality has been a long-standing priority in the European Union, and legislation such as work-life balance that we've processed recently and is coming into play has been really important, but much more work needs to be done. We need all to work together. We need to make sure that maternity care will be safe, of high quality, and offer better experience and more choice to women and their families. So with that, I'm going to hand you back over to a chair for our meeting, Ms. Peggy Maguire. Thank you for your attention.
Thank you very, very much, Deirdre, for those words. We really appreciate it. Just now, we'd like to hand over to our researchers who have completed the research on maternal health in the EU. We have Mairead Finn, who is a researcher working in the areas of social policy, migration and health systems. And at EU level, she's worked to examine indicators on the quality of employment across EU member states, as well as changes to social protection measures for youth in the EU during the Great Recession. She has extensive experience. She's researched migrant women's housing experiences in rural Ireland and access to education for girls with disability in Guinea, and gender norms within families that impact access to food and contribute to child stunting in Malawi. And our second researcher, her partner, Morgan Clark, who joined DOCAS as Programme Support Officer in 2021. And prior to joining DOCAS, she worked as a health systems researcher with the Royal College of Surgeons team of the scaling up of safe surgery for district and rural populations in the Africa project. Morgan is driven towards collaborative work which promotes human rights with a particular interest in how gender and power dynamics influence equity and equality. So I'll hand over to you, Mairead, now, and we look forward to hearing your presentation. Thank you very much.
Thank you very much, Peggy. Let's share my screen, just 2 seconds while I get this. Okay, can everybody see okay?
Yeah.
So, perfect. So thanks a lot. Thank you very much, Peggy and Deirdre, for that introduction. So this presentation is about 20 minutes, just a broad review of some of the key findings from this report commissioned by the European Institute for Women's Health in 2021. So myself and Morgan worked on it together beginning in March 21, and we are just presenting some of the more salient findings today. So it's quite a large report and quite a lot of detail in it. And I suppose today's presentation is just a broad brush sweep of some of the most salient issues. And so if I can just go to the aims and objectives, it was very much focusing on trends and disparities in maternal health and care outcomes across the European Union. So we wanted to establish a knowledge base on maternal health with a view to supporting action to improve maternal health, maternal care, and to realise the right to safe pregnancies for the diverse body of women within the European Union, and really recognising the diversity among women across the European Union, and thinking very much about trends and disparities. So the review, it was a literature review, a desk review, and the objectives were to summarise available evidence, including statistics on maternal health and access to care, and then to map evidence on prevention strategies to guard against risks to maternal health and to identify barriers which prevent access to quality maternal health services at all levels. So as a literature review, we looked at available statistical sources, such as Eurostat and Peristat, but also into the published literature and grey literature as well. So it's a broad sweep of the existing evidence base. And I suppose, what do we mean by maternal health in the European Union? So, I mean, it encompasses the health of a woman during pregnancy, childbirth, and the postpartum period, but also linking directly to broader aspects of health that precede and underpin maternal health. And this includes a woman's general health and also related to family planning. So this broad view of the general health of a woman, which pregnancy is one part. And it represents a paradigm shift in the maternal health agenda from preventing maternal death, so this more limited kind of this outcome measure, but also to promoting women's health and wellness. So that we think about women's health in terms of thriving and well-being, and how pregnancy and a woman's maternal health is a part of that. And within this paradigm, pregnancy is viewed as a window of opportunity into the current and future health of women. So it offers a critical entry point for women who may otherwise not seek or have access to care for chronic conditions. So that this, this point in time is an opportunity for increased engagement with health services. And I guess this quote, which Deirdre mentioned too, we have, that the health of a woman has direct bearing on the health of future generations, their families and communities, and ultimately the health of societies. But not just, the role within society, but also the personhood and autonomy of a woman herself. So that, and the rights of all mothers to realise good health in relation to their maternal care. So while we may have a right to health, that does not mean that this is in practice there, that we may not have actual access. And I guess when we look at disparities and trends across the European Union, we can realise that a lot of women might not be able to realise their rights in relation to good health. So this is an important concept and something that in understanding trends and disparities will help us to recognise areas for strengthening. So just to review some key facts and figures, a broad brush sweep of facts across the European Union. 5 million women were pregnant each year to 2020, and in 2019, 4.2 million babies were born in the European Union. So 1.53 on average live births per woman in the EU, and then of course there are trends across the different member states. So we had a minimum in Malta and a maximum in France, for example, and the average age of giving birth is 29 years across the EU. But the rate of women who are older is increasing. So those who are 35 years or older at first birth is an increasing rate, with an average of 21% of mothers who are over 35 years, and then a higher rate in some countries of the European Union and lower rates with other countries. And of course, when we think about disparities, we're talking about disparities across the European Union itself, but also within the population in terms of demographic features of women across the Union. So we're not just looking at trends, we're looking at trends across the European Union member states, but also within the population of the Union itself. And then nearly half of all pregnancies in the EU are unplanned, with just over half planned, so diversity of circumstances entering into pregnancy there. And then there are improved outcomes in general, but there are high geographic and socioeconomic heterogeneity in rates of stillbirth, for example, in neonatal mortality, preterm births, low birth weight, and mode of delivery. So while there may be, stronger outcomes in this region, perhaps by comparison globally, there is still heterogeneity and issues that need to be addressed and strengthened. So we have to be mindful of this within our work. So today's findings, as I mentioned, are a very broad brush sweep. I'm not, I suppose, delving too much into statistics, in detail. It's more a broad kind of nod to different trends that we want to highlight. But this is around the table of contents of the report itself. So we looked initially at the maternal health care journey. So looking at these particular topics for women in their maternal health care, and then we looked at the maternal health care context and covered these topics here. So the socioeconomic support around the time of birth, disparities and vulnerabilities, so taking a stronger focus on this within this section, and then looking at research data and investment and policy in Europe. So today I'm going to focus more so on the first half of the report, focusing on women themselves and their experiences, and we'll see some of the policy recommendations related to the maternal health context. So we'll address that more broadly towards the end, but not review within the substantive content. So some of the key points for today are that there are improved outcomes, but that high geographic and socioeconomic heterogeneity remains. So for example, rates of stillbirth and neonatal mortality, preterm birth, low birth weight, and low delivery. And that there hasn't been an increase since 2010 in many risk factors related to maternal health. So for example, related to age or body mass index or migration status. And that understanding these risk factors and particular conditions is important for improving circumstances for women in relation to their maternal health and having a proper systems response to this. And that disparities across populations in relation to health conditions, access to care and maternal health outcomes manifest in socioeconomic terms, but also in geographic terms across the Union as well. And this report is, maps out what those disparities are, I guess, and what the evidence is on that. So just a quick turn towards public health, health promotion and disease prevention. We reviewed the risk factors that contribute to adverse maternal and child health outcomes. So risk factors related to socioeconomic situation, underlying health conditions that may prevail, or perhaps, for example, a healthy body mass index, and reviewed different interventions for health promotion and disease prevention. So, understanding how we might support women's health in a way that's empowering in relation to nutrition, exercise, and support behaviours that will help to support healthy life choices and healthy behaviour. But for example, in relation to data that the European Health Information Gateway details rates of influenza coverage for pregnant women across the EU according to country. So this information is available across the EU. But that, for example, what is required perhaps is common European standardised dietary methods or dietary reference values, and perhaps greater coordination could take place on this availability of this data across the European Union. So we reviewed also approaches to health promotion and disease prevention. So for example, screening and behaviour change, and how supporting protective behaviour, but alleviating behaviour with harmful effects. And again, just some examples from a coordinating perspective that, for example, there's no consensus on an optimal approach to gestation to GDM screening in Europe, and that it is recommended that this uniformity would lead to a timely diagnosis and to treatment for a greater number of women. And also, in terms of trends around obesity rates, these range from 7 to 25%, and they be strongly related to social and educational inequalities. But most European countries do not systematically report these figures in their pregnant population. So again, thinking about how we can, I suppose, work with women in ways that are empowering for them in relation to their health around the time of pregnancy and before it and leading up to pregnancy as well. So in terms of access to care and information, we worked with this particular framework. It's a 5 A's framework with dimensions of access. It conceptualizes access in terms of approachability, acceptability, availability and accommodation, affordability and appropriateness. I suppose in thinking about rights of access to healthcare, this gives us an indication of the types of domains that we need to consider for women. And also within that, then there are 5 corresponding abilities of the population to support access. So the ability to perceive, the ability to seek, the ability to reach, and the ability to pay, and the ability to engage. And that supporting these abilities within the population are really important, and understanding where disparities in those abilities might manifest. So within the report itself, we documented examples of disparities in this regard. I suppose, a lot of these would come to mind from our general knowledge, but we went through the evidence itself in relation to, the ability to pay for those women who are living in poverty, for specific groups such as vulnerable and undocumented pregnant women who might be in a less secure financial situation. And that when we look at trends as well in relation to migration status and ethnicity, we see the maternal mortality rate for women with non-Western origin is far higher. So really, recognizing these disparities and how we can work to address them. And then the lack of access to pharmaceuticals due to cost. And so, what lies underneath these is the interplay of health systems, laws, policies, socioeconomic factors, and attitudes of health professionals and users. But I suppose the very national trends in relation to what underpins these disparities. And we try to map the evidence on this so we can understand the picture across the European Union and then for groups of the population within the region. So turning to labour, birth and delivery, there are vast differences in the mode of delivery across Europe, which have persisted in recent years. If we look at caesarean section rates, for example, the median across the EU is 27%, and then there are, of course, national variations as well. In some countries it's lower, under 20%, under 18%, and in other countries it's far higher, over 35%. But that rates have increased as well across the EU over time. So, I suppose acknowledging these trends in relation to labour, birth and delivery. And maternal deaths, they remain lower. While they do remain lower in many other than many other regions, there are still issues that prevail. And so when maternal deaths do take place, it's often related to substandard and poor quality care. So being able to ensure quality care in all areas, and that there can be evidence of increased risk among particular sections. So we have to address health issues for older mothers or for birth by caesarean section. And the three most prevalent causes of maternal death were embolism, hypertensive disease, and hemorrhage. So understanding the evidence on this and how we can work to address it in policy terms across the EU. And while I suppose the rates of mortality and morbidity might be lower, we need to understand these particular risk factors and how they influence and are part of the experience within the European Union. So turning to safe use of medication and disparities within this, there is a lack of a robust and comprehensive regulatory and information system regarding that addresses safe medicine use during pregnancy. And I guess the disparity is around the use of safe medicines in general, so that while 90% of pregnant women do take medicines during their pregnancy, 90% of medications have no information about their potential to cause birth defects. And about 20% of women have difficulties understanding information given about medicines during pregnancy. So being able to work, in a way that information about this is salient and accessible. And really within research as well, within clinical trials, how pregnant and lactating women are mostly excluded from this. So we're lacking in data according to sex and gender, which gives us insight into the impact of these on women and particularly pregnant women and lactating women. So being able to include this within research and data collection is very important. There is a demand for information and also for improved health literacy about safe use of medication. And these recommendations we wanted to highlight from the European Medicines Agency, that systemic collection and analysis of data from the multiple routine interactions between women and their healthcare professionals is desired. And women's participation in clinical trials should be considered more routinely. So we want to complement and interact with existing initiatives as well as with additional population-based cohorts. Another section of the report is on health condition management, and I won't go into, I suppose, some of the stats per se here, just to flag that we reviewed it in relation to these particular areas. So working with health conditions for women throughout pregnancy and childbirth, and thinking about the intersecting nature of women's health and how that is treated. So we reviewed these sections as well, and again, working with mothers in a way that really foregrounds their agency and the intersectional nature of their identity and health throughout pregnancy and childbirth is our priority. So turning towards some of the recommendations, we conceptualize these steps for action. So, moving from enactment, I suppose, particular categories of steps for action at policy level. And if I turn to this table here, we can see some of the various ways in which we've recommended actions within existing EU policies or directives or legislation, and also specifically focusing on addressing the trends and disparities that women may experience in pregnancy and childbirth across the European Union. So we've promoted a suite of activities or in relation to addressing the trends and disparities in maternal care across the EU. And these are, I suppose, quite detailed in the report in different pages, but we've summarised them here within this table, and really with a view to, I suppose, integrating and coordinating with existing initiatives, but also foregrounding and highlighting women's experiences and women's voices, and particularly taking this transformative approach to the way of working with women within their maternal care. So our high-level recommendations are really around that: the promotion of health and well-being, having a person-centered and rights-based approach, and working with research, so that that our conceptualization of pregnancy is that it's viewed as a regular event that takes place at a particular time within a woman's life, and that health promotion is taken early and at critical points from childhood through to older age. So we want a life course approach to good health and well-being rather than intervention during birth itself, with pregnancy as a psychosocial opportunity to empower women to lead healthy lifestyles. And within the person-centered and rights-based approach, we have a transformative approach that foregrounds women's voices and personhood within their care, and really centres on their agency within the process. And we want to connect with patient public participation, patient advocacy and partnership, and draw on implementation science and research to exercise rights. So really have, implementing a more citizen-based approach that Deirdre mentioned at the outset. We can link in with existing instruments, for example, accelerating the health literacy agenda in Europe, and then framing access to maternal health as a human right. So this reflects an earlier piece of work a few years ago, access to maternal health and midwifery services for vulnerable populations. And then with research itself, in relation to data, I suppose one of the issues is the, gaps in standardization of gathering national data on a whole host of topics and domains. So with member states and the effort to collect data and to feed in standardized data from different member states in the European Union, but that we need to continue work in this regard to capture representative and better quality data from across the different member states. And then that we can also explore possibilities of standardization of indicators across the European Union. So for example, in relation to nutrition and diabetes, it's important to prioritize data and analysis to capture inequity among women. So for example, recognizing the full diversity within women. So for example, with age, socioeconomic status, migration and citizenship situation, and ethnicity, and recognizing the intersectional nature of inequity. And then addressing sex and gender in research. So in relation to clinical trials, that we have data disaggregated by sex, gender, and age. And we must also incorporate analysis of gender within power and decision-making in health systems. This is an important area as well in understanding the delivery of healthcare. And so adopting a systems thinking approach to maternal healthcare research as well also gives us that wide view of the different aspects of the healthcare system and where gaps might be. So I'll leave it there. I wanted to connect into work that has already taken place. We carried out this report, building an evidence base on information on trends and disparities, but an important document we included as well was from 2019 on access to maternal health and midwifery for vulnerable groups in the European Union. So I really want to acknowledge, I suppose the body of work that's already done, and that this builds on that, and any actions would build on that. And also this event moving forward on maternal health in Europe within the European Parliament, so that there's a lot of, I suppose, existing efforts and initiatives, and that the coordination and building on work that's been done is very important. And again, just to finish off with the same quote from the outset, that the UN Convention of the Rights of the Child requires the right to receive appropriate prenatal and postnatal health care for all mothers. That when we think about access, what groups across the EU might struggle to realise that access, and the importance of, within a transformative approach in recognising women's voices, that in the actual practice of healthcare and recognising a woman's voice within the healthcare journey, that is of paramount importance really, and this transformative view of how we view women within maternal care is extremely important. So I'll leave it there. I'll hand back over to Peggy, and look forward to the contributions from the other panelists.
Thank you very, very much, Mairead. Such a comprehensive and the summary of the report. Really appreciate the work that you and Morgan have done on this, and working with you has been a great pleasure. It really has. So we look forward to the publication of the report, which will be in April this year. It's still being reviewed by our experts, but Mairead and Morgan are continuing to work on the project until April, until it's completed. And of course, we'll make it available to everybody on the website. And if anybody wants a hard copy, we're happy to do that as well. As you can see from Mairead's presentation, the actual report is very comprehensive. It's wide-ranging, and for that reason, I hope we've put together an expert panel for discussing the issue around maternal health in the EU. First of all, we have Dr. Alison Carroll-Moran, who is the head of the Department for Maternal, Newborn, Child and Adolescent Health in the WHO. We have Dr. Isabel Della Matta, who is the Principal Advisor in the EU Commission DG Sante. We have Gavin Ash, who is from the Department of Health in Ireland and working with the National Maternity Strategy in the Department of Health. We then have Dr. Vanessa Moore, the European Institute of Women's Health, who will give a presentation on the Conception Project, in which we're a partner. We then have the president of the European Midwives Association, Agnes Simons, who is actually working at the moment, so will not be here till later. And we're very happy to have Mervyn Yuckin, who is the past president of the European Midwives Association, here with us today. Professor Alexander Kowski-Willer from the University of Vienna, and also head of the Gender and Medicine Unit there. Very welcome, Alexander. Dr. Heidi Siller, the Psychology Department in the University of Klagenfurt in Austria. Professor Miriam Schulder-Ossen, Charité in Berlin, and also a member of the board of the European Psychiatric Society. And I also know that we have Corinne de Vries here from the European Medicines Agency. I'm not sure if she wants to sit on the panel. So thank you very, very much, all our experts today. You're all very, very welcome, all experts in your own field and all contributing to the issues around maternal health. I'd like to ask our first expert panelist, who is from the WHO, Dr. Alison Carroll-Moran. I have a specific question for you, Carolyn, that I hope that you find relevant to the discussion here today. So I'll just start off with you. Who has conceptualized a framework for improving the quality of care for women and newborns around the time of childbirth, encompassing both the provision and experience of care? Standards and accompanying quality measures explicitly define what is required to achieve high quality care around the time of childbirth. Could you tell us here today, how can this framework and the standards support better care for women and their babies? Over to you, Alison.
Great, thank you so much. And just to thank the organizers for including me today. It's an honor to be here and hear the results of the very exciting report that you've put together. Just a quick clarification, my name is Alison Moran and I work at WHO in the Department of Maternal, Newborn, Child, Adolescent Health and Aging, and I lead our maternal health team. So thank you very much for that question. I think as we saw in the presentation, and I'm sure we'll see in the report, we know that quality of care is really an essential component to continue to reduce mortality and prevent future deaths. We know from the literature that more than 50% of deaths, 50% of maternal deaths and 58% of newborn deaths can be prevented if all women had access to high quality care. So as you alluded to in the question, in 2015, WHO elucidated and published a conceptual framework on quality of care that encompasses both the provision and the experience of care within health systems functions. So we wanted to ensure that we have equal weight on both the provision of clinical services and care, but also on how the woman and her family experience the care, as those are equally important. So we first developed the framework as a focus to really look at maternal and newborn care, specifically around the time of childbirth. But the framework has since been also adapted and used to look at quality of services for pediatric care, as well as for small and sick newborns, which are an especially vulnerable group. So in addition to a focus on the provision and experience of care, there are about 8 domains within the health system that we're suggesting should be assessed, improved, and monitored within the context of different health systems. So just to state what those domains are, and I'm happy to share a link to this publication if that would be helpful. But the first 3 are under the domain of provision of care and look at evidence-based practices for routine care and management of complications. And that would include those obstetric complications as well as non-obstetric. The second domain is around actionable information systems, and the third is around functional referral systems. The next 3 domains are under experience of care and really look at supporting and strengthening effective communication, respect and preservation of dignity, and emotional support. And then the last 2 domains are essential across the board and relate to the competent and motivated human resources and a health workforce, as well as availability of essential physical resources like commodities, drugs, supplies. So in order to think about how to operationalize this conceptual framework, we've developed standards of care, and each of those domains is supported by 1 standard of care and then accompanying quality statements. And the idea behind this is to help operationalize them. So for example, I'll just give it 1 example. So if we look at the domain around effective referral systems, we have a standard that addresses that, and then 3 quality statements under it that look at ensuring women and newborns are appropriately assessed on admission and referred if they're not able to be managed in that facility or at that level. And the second quality statement is around if women and newborns require for referral, that there's a pre-established plan that can be implemented without delay. And then the third one is for women and newborns referred within and between facilities, is there appropriate information exchange among the staff. And then if we look at the standard, one of the standards under experience of care, for example, we have an explicit standard on women and newborns receiving care with respect and preservation of dignity. And that first quality statement is looking at privacy around the time of labor and birth, ensuring that women and newborns are not subjected to mistreatment or abuse or discrimination. And then the third one is that all women have informed choices in the services they receive. So that's just an example for you. And so the idea is that these standards can help explicitly define what's required to achieve high quality care around the time of birth, to set benchmarks against which improvements can be measured, and to drive and monitor quality of care improvement. So just to give an example of how we've been working with countries to try to implement these standards to improve quality of care. We've worked a lot in preparing national standards and adapting what exists in different countries to ensure that these standards, all of them, are included in those types of, in the national level standards of care, as well as at national and at subnational levels. I think one of the interesting findings from this report were really a lot of the disparities that we see coming out along different lines. And so ensuring that these standards are also adapted for vulnerable groups, women with risk factors, but also different ethnic vulnerable groups is really essential. And then to really try to introduce these standards within health systems and within existing programs. And then importantly, to align and use available resources and the monitoring piece as well. I think that came out quite strongly in the report, the need to really have standardized indicators to monitor the standards so that we can really see how changes are occurring, so that that information can be used to continually improve the quality within different facilities, as well as benchmarks on how different programs are being implemented. So I think there's a lot of opportunities that we can think about together of how to strengthen this agenda, and really looking at strengthening the quality of care to improve not only maternal survival, but also well-being. Currently, this framework is really more focused on survival and reducing mortality, but I do think there might be an opportunity to look beyond that as well and think about how we adapted to address some of the important elements that were highlighted in the presentation today. So that's all from my side. Back over to you, Peggy, and happy to answer any questions.
Thank you very, very much, Alison. I'm not too sure if there's any questions at the moment, Marlene. Marlene is monitoring all our questions in the chat. So she's going to let us know if anybody has any questions for any of the speakers. Thank you so much, Alison. I think there is an awful lot more work to be done. And I think working together, I think moving forward with this agenda, I said we have an opportunity to improve the health, maternal health for all women. Next, I'd like to go to Isabel Della Matta, Dr. Isabel Della Matta, who is the Principal Advisor for Health and Crisis Management at the European Commission. And I'm sure, Isabel, you've been very busy and still are very busy over the last number of years with the COVID-19 pandemic. And we've learned from the COVID-19 pandemic that infectious diseases know no boundaries and no borders. And infectious diseases have posed and continue to pose serious threats to public health. Why do you think it's important for pregnant women to consider vaccination, even now against COVID-19? And what other vaccinations are important for pregnant women? Thank you, Isabel.
Thank you very much, Peggy. Good afternoon to everybody. The Commissioner Kyriakides has already made clear, and even in Twitter, so for everybody, that vaccines are effective, COVID-19 vaccines are effective at reducing the risk of hospitalization and death in pregnant women as they are in non-pregnant women, and that they don't cause complications for mothers or their babies, and asking, get your vaccine, protect your baby. So that was done the day that the European Medicines Agency also launched this the press report talking about vaccines. I'm not going to enter in that because I know that the EMA is here in the meeting, so she will explain the position. But what I want to say is that our position has been clear. The vaccines against COVID-19 are important for the women in the same way that for the pregnant women, in the same way that are necessary other vaccines. Regarding the COVID-19, it's not just the EMA, but other institutions that have made clear the position. We are always referring the European Board and College of Obstetrics and Gynecology that also made clear that pregnant women are urged to get a COVID-19 vaccine, as well as the booster shot, the CDC, United States Center for Disease Control, and also there is this project that aims to undertake a living systematic review involving pregnant and postnatal women at risk, suspected and diagnosed to have COVID-19, and synthesize all the relevant evidence on prevalent risk factors, mother-child transmission, diagnosis, treatment, etc. That is in the University of Birmingham. We know that women in general, and even less pregnant women, are not part in many clinical trials. This is something that the new legislation on clinical trials try to remediate, and the inclusion of all the groups, including women, and of course pregnant women in the clinical trials. The ECDC also from the beginning made clear that there is a risk of infection in pregnant women and in the newborn babies, and that this should be considered in the vaccination in line with the relevant national recommendation, as antibodies could also protect the fetus and the baby, and that no pregnancy complications have been reported after vaccination. So, that to summarize, that the European Union, the European Commission position concerning the vaccination of women is quite clear, of pregnant women, sorry, is quite clear. So why this push, this doubt, this discussion that we had about pregnancy and vaccination? Not only COVID-19, but the vaccines in general. And for that, I would like also to refer to the report on the state of vaccine confidence in the European Union plus the UK, that the last one was 2020, and we published last year, 2021. And now we are preparing the next report, as we are doing this state of vaccine confidence every 2 years. So, and what we saw in that report from 2020 is that the percentage of healthcare professionals that are confident with some vaccines, and specifically we requested about the seasonal influenza vaccine and pregnant women, they are not so confident, and they are not so willing in recommending this vaccine to the patients, I mean, to the pregnant women they are dealing with that. And when, while for MMR vaccine, I mean, health professionals are quite confident in general, small differences, but in general quite confident. For seasonal influenza vaccine to patients in general, yes, they are quite confident and willing to recommend, but not when this is about pregnant women. Also to HPV vaccine, no problem in general, even if the confidence is less than for MMR. But so why with seasonal influenza vaccine and pregnant women? What happened with the pregnant women that the professionals still have doubts? And here I think, and we are working a lot with the coalition on vaccination that is made by the main healthcare professional associations and students and some others. We are working with the health professionals, and I think that this comes back to the education. I'm a medical doctor. I receive education in vaccination, and we were always told that vaccines, we had to avoid vaccines in the first trimester of the pregnancy. At that time, we were talking about attenuated virus. We were talking a lot. We were discussing at that moment, for example, about rubella and the effect that attenuated virus could have in the pregnancy and potential malformations and etc. So especially in the first trimester. So I think that something stayed in the minds of the healthcare professionals. The information was not updated. We didn't take into consideration the new form of vaccines, not even that inactivated virus or bacteria are used more and more on vaccines, and that is residual, the use of attenuated one. The new, like in the COVID-19, new formation of vaccines, and in the same way that the healthcare professionals need an update in all the areas, also on vaccination, and the population too. So I think that we need still to continue the work that we are doing with the coalition on vaccination, the work on dissemination and making more available actual information, right information to the general public, as we are doing with the ECDC and the European Information Portal on vaccination. We need to continue to pass the right messages. We need to take into consideration and to pass the message that vaccination are not just for children, vaccination are not just for elderly, but vaccination is something that applies to the whole of the life of the person. That we need to study, we need to carefully consider all the different population when doing the clinical trials, to measure the potential impacts that for good and for bad, I mean the secondary effect, but also the protection effect that the vaccine have in the population, and that we need to consider, to stop considering that vaccines are not for pregnancy, and to begin to include, when necessary and when adequate, and taking into account the national guidelines and the general guidelines that the vaccines are also for pregnancy and also for pregnant women, and that could be an important part of the protection and having a safe pregnancy and healthy babies and healthy mothers too. So we will continue to work in this direction for general vaccines, for the COVID-19 vaccines. We continue to work with the EMA and with the ECDC, and we will continue to deliver the information that we will have available, and continue the discussions with the health professionals and with other stakeholders like the European Institute of Women's Health. And I wanted to say that we are very happy with the report, what we have seen of the report, the draft, and that this is something that we are thankful for the European Institute of Women's Health to put that in the spot, to make available and to continue the work that they are doing on that. Thank you very much.
Thank you very, very much, Isabel, for that very, very comprehensive explanation on the Commission's position on vaccination. And as you probably know, the European Institute of Women's Health feels very strongly about vaccination over the life course for women, and how important it is that we promote, and everybody promotes, vaccination across the life course. And of course, women as the carers of family are often the ones that bring their children to be vaccinated, and also, of course, look after older people as well. So it's such an important role for women in health promotion. That's one of the topics that we're covering in the report, that area of health promotion, and vaccination is a specific topic that we're covering. Thanks very, very much, Isabel. So we've had the World Health Organization perspective, and we've had the Commission telling us about vaccination and the importance of vaccination in pregnancy, and of course the life course as well. So now we're going down to the national context, and I'm very happy to welcome Gavin Ash from the Department of Health in Ireland. Gavin works in the National Maternity Strategy in the department, and he works with the Maternity and Gynecology Policy Unit in the Department of Health. His work centres on the oversight of the implementation of Ireland's National Maternity Strategy, on the governance of maternity services nationally, including liaison with the Health Service Executive, which is the implementation arm of the Department of Health, the National Women and Infants Health Programme, and on patient safety and quality in maternity services. I'd also like to say that Gavin also works and is a member of the Women's Health Task Force that I co-chair, and it's been a pleasure working with Gavin over the last 2 years. So Gavin, over to you. We're very interested to hear about the Irish National Maternity Strategy.
Okay. Thanks very much, Peggy, and thanks to Maureen as well for her rundown through the report, and hello to everybody else in the call. Just for those who might not be familiar with the strategy itself, it's Ireland's first national maternity strategy, and it was published in 2016. At its core, it aims to increase choice to women while making services more safe, more compassionate, and more readily available, regardless of location. The strategy is built on a model of care that has 3 care pathways. These are the 3 pillars of the model of care. So it's supported, assisted, and specialized, depending on the complexity of the care required. The core aim really of the model of care itself is to ensure that women can access the right care from the right person in the right place at the right time. Before I go into the details of the strategy itself, it might be useful to give a sort of background context to its developments. So prior to the publication of the strategy, there was an absence of a centrally agreed model of care for maternity services in the country. This meant really that services weren't standardized and they weren't readily available, despite there being a range of services available in the country. It generally depended on where you were or how close you were, or your proximity to a tertiary unit. All of our services are delivered in either a state-run hospital or a voluntary-run hospital. At the time, or just before the publication of the strategy, despite the fact that Ireland is statistically quite a safe place to be pregnant and give birth, a number of high-profile cases and reports The most prominent of which obviously was HEPA's report into the death of Savita Halbanavar, and our own Chief Medical Officer's report into a series of perinatal deaths. They served to undermine public confidence in the service, quite apart from the devastation that they caused to the families obviously involved, and they had a serious impact on the morale of staff across the system. The report into Savita's death in particular specifically recommended that a strategy be developed to implement standard, consistent models of care for delivery of a national maternity service. There was a national view that they were taking on the entire service, and it was against that backdrop and in line with that recommendation that a ministerial commitment was made to develop the strategy. So then it was handed over to us in the unit, I suppose, to drive that. And what we saw first is this offered a unique opportunity, I suppose, to examine the entire service, but also to build a new model of care from the ground up, or from the centre out, which is probably a more accurate way to describe it. So we put together a steering group, academics, senior clinicians, senior midwives, service user representatives, and policymakers like myself, to draw on as much evidence and put together as strong an evidence base as possible for a strategy. But what was in agreement from the very start was that the voices and experiences of the women who access the services in Ireland were probably going to be the most crucial thing to developing a successful strategy. So to achieve this, the department ran a national public consultation with about 1,350 detailed qualitative responses, and we ran focus groups targeted at women from marginalised groups who may not have readily accessed the survey online, if it will. It was those voices really that drove the direction of the steering group and helped frame the importance and the necessity of the strategy. So what came out of that then was a strategy whose main objective was to deliver a service where women and babies have access to safe, high quality care in a setting that's most appropriate to their needs, where women and family were placed at the centre of all services and are treated with dignity, respect and compassion, and where parents are supported before, during and after pregnancy to allow them to give the best possible start in life to their child. So the question is, are we successful? Are we on the road to that? It's a yes and no thing. We're about halfway through implementing the strategy. So yes, we have made significant progress, but no, we're not quite there yet. We still have about 5 years to run on the strategy. We have made good progress, and we've invested about 26 million in development funding, and we've added about close enough to 400 full-time posts to the service overall. Progress in terms of the strategy's implementation plan, we're at about 61 or 62% complete, with 25% of those actions ongoing or in progress, and we have about 16% to start. So our key improvements probably started, or they had to start, with the governance and the workforce and structure of the service itself. We had to build it from the top down in that sense. So in 2017, we established the National Women and Infants Health Programme in the HSE to drive the implementation of the strategy and to act as, very importantly, as a central authority and a reference point for women's health on a national level, something that we didn't have before, and something that was very important to put in so that the strategy had something to kind of hang on, if you will. We established clinical maternity networks in each of our hospital groups to provide improved governance and improved guidance and oversight. And we appointed a lot more senior clinicians and senior midwives across the service in decision-making roles. Particularly, it's very important, a director of midwifery was appointed to each individual unit to make sure that there was a senior midwifery voice at the table, at the senior management table, so that when decisions were being made, that voice was there. Safety and quality was also a key priority at the start. And we put in place quality and safety managers in each hospital group, as well as maternity-specific serious incident management forums. All of our 19 hospitals are now publishing monthly maternity safety statements, which is very important for us to track exactly any issues that might be arising. We can catch them quickly. And in terms of the services themselves, now all women 100% are offered routine dating and anatomy scans as a matter of standard in all of our units. Perhaps the biggest impact on service users themselves, because they won't really see quality or safety and quality improvements or governance improvements. They will see the improvements in the choices of the services that are available to them. So we've invested quite heavily in that, and in particular in the expansion of midwifery care and the provision of community-based services, which means, of course, that more women can now access greater range of services in their own communities. This is a particular benefit to all women, but it really benefits women from rural areas, women with different abilities, women from marginalised groups who are far more likely to access services if they're available locally. Maternity services have now moved some of their services online as a result of COVID, but I think it's worked quite well and they're holding on to it. So we have virtual consultations and we have virtual and remote monitoring of women. We've also implemented our supported care pathway, which is one of the 3 pillars of the model of care. And that's now available in all 19 hospitals. That's up from 6 in 2016. Currently, we have about 35–40% of women being offered it on a clinical basis. And we have, in 2020, I think it was, we had 24% of women being managed fully right through to birth in that pathway, which is a great success considering where we had come from previously. In terms of the infrastructure, people will notice that we're starting to demedicalize the process. So we have now rolled out 9 or 10 home away from home birth units, which is a non-medical environment within the hospital itself. And we have another further 5 of those in development, which really makes the supported care pathway work really smoothly. In terms of health and well-being, we now have much greater access to the wraparound services, which is the outside of the model of care, I suppose you might call it. We have more dietetics and more physiotherapy and social worker services available, ensuring greater access, but also greater access locally. We're rolling out a perinatal mental health model of care, which is very important. We're not quite there with that yet, but it is expanding and the services are becoming more and more available to women. We have bereavement services introduced in all of our units now, and we have specialist bereavement midwife available on site in every hospital. What's important is that the referral pathways between these services and into these services have become standardized across the country, which is a key aim of the strategy to begin with. So it doesn't matter where in the country you are, you can access it because the referrals are there. And in order to capture, I suppose, improvements as they come online, we've developed and rolled out a national maternity experience survey. The first one of those we ran in 2020, and we had largely good results, but we were able to generate improvement plans for each unit as the results came in. In terms of the broader picture of women's healthcare, for me, I think the National Maternity Strategy was the first big step to placing women's healthcare on a national and political agenda on a permanent footing. So it's been there since that time. We've seen a growing momentum, I suppose, behind the issue of women's healthcare, and that's culminated in the Women's Health Task Force, as Peggy has mentioned there, and in the upcoming publication of the Women's Health Action Plan, which is coming out of the task force. I think incorporating the implementation of the strategy within the plan reflects the importance of maternity care for addressing a broader spectrum of women's health, right across the board, from mental health to drug and alcohol abuse to even to domestic violence. All of this can be captured in a maternity setting with good and with well-designed maternity care. So I see the strategy becoming, I suppose, a really important part, and retaining its place as an important part in terms of the overall effort to improve women's healthcare in general. On a final point, I will say that over the course of my time working in this area, I've seen the issue of genuine and truthful engagement with stakeholders, and particularly service users, move from being rare and outlier to becoming more commonplace now. It's my hope that will continue, that trend will continue, and if anything can be taken away from our experience with the National Maternity Strategy and the work of the Women's Health Task Force, I believe it should be that. Thank you, Peggy.
Thank you very, very much, Gavin, for that very good and very clear explanation of how the National Maternity Strategy was brought about. I think the National Maternity Strategy in Ireland is a very, very good model as to how policymakers have actually consulted with the stakeholders and particularly with the end user, the woman, to make sure that they're getting the proper care at the right time and where they need it. Without any discrimination. And really, I think it's a good model. I think I'm very proud to say for the rest of Europe. And I think Gavin and the department have done a fantastic job in relations to women's health. Thank you very, very much, Gavin. Thank you.
Thank you, Peggy. Thank you.
We'd like to move on now to another issue and a topic, and that's in our report, and that is the issue of safety of medicines in pregnancy. This is a huge issue. Sick women get pregnant, and pregnant women get sick. And it's just an area now that we've been working on for quite a number of years. And particularly our former board member and president, Hilton Sunset, has done a considerable amount of work over the years on highlighting the issue around the safety of medicines in pregnancy. We're very proud of that. And thank you, Hilton, for doing that. I'm very happy to introduce Vanessa Moore, who worked on the Conception Project. Vanessa has contributed to the EIWH's work in the area of gender, vaccination access and uptake across the lifespan, as well as chronic diseases, older people and public health. She's been involved in the EIWH policy briefs, extensive policy briefs on diabetes, heart disease, lung cancer and others. And also Vanessa has highlighted sex and gender issues at several conferences and meetings at a European and international level. So Vanessa, I have a question for you in relation to safety of medicines in pregnancy, which very much goes back to our report again. What has been found is there's a lack of information about the safe use of medication during pregnancy and lactation for both women and also for their healthcare professionals. And many women need to take medication during pregnancy to manage their health condition. So in some cases, avoiding or stopping medication isn't an issue. It can't be done because it could be harmful. So then taking a medication as more women postpone pregnancy is going to be an issue moving forward. So the use of medicines during pregnancy is likely to increase. So just to say that the European Institute of Women's Health is a partner in the Innovative Medicines Initiative funded project called Conception, which Vanessa is working in. And now Vanessa is going to give a presentation on why it's so important to consider safety of medicines in pregnancy and why the Conception project and the results of that project is so important. Thank you very much, Vanessa.
Thanks, Peggy. Good afternoon, everybody. I'll share my screen quickly. I only have a few slides. I hope everybody can see that. So yeah, so like Peggy pointed out, safety of medicines in pregnancy is a huge issue. Conception, the project, is a public-private partnership co-funded by the IMI initiative, and it's co-led by Novartis and the University Medical Center Utrecht. It's a 5-year project, so started in 2019, due to run to 2024, and the total funding is 28 million euros. So it's a large project. There is a large amount of partners, as you can see. There are 51 partners, 7 linked third parties and 28 third parties, and there's over 200 researchers from 22 countries. So an awful lot of partners, of which EIWH are one, like Peggy said. So the kind of mission behind Conception is to build and test a trustworthy pan-European ecosystem that's to generate, monitor and provide robust and rapid evidence on medication safety in pregnancy and breastfeeding. This is to be done in a collaborative and a standardized manner in order to inform women, families and healthcare professionals about the safety of taking medication in pregnancy and also in breastfeeding. Just, why is this a problem? What's the rationale behind all this? Well, there's a huge need for proper evidence. Like Peggy said, drugs are frequently used during pregnancy. Sick women get pregnant, pregnant women get sick. You can see here this slide from a 2011 study that showed that the percentages there to your left are the percentage of pregnant women who take one or more drug during pregnancy, and it's obviously very high. And sometimes maybe it's only temporarily, sometimes it's for chronic illness, it could be anything, and there's just not enough known about the safety of it. The Conception Project feels that the woman has a right to a safe and effective use on medication that's based on actually scientific evidence that is a firm evidence-based. Globally, 200 million women get pregnant each year. 5 million of these are in the EU. So it's, it's not a niche issue. It's an issue that really affects a lot of people. Women who have chronic illnesses or, any kind of trouble or that get ill during pregnancy take medication. It is a high use. Proper evidence, kind of systematic evidence, is largely lacking, or it's incomplete or unknown. There's a lot of fragmentation in what we know and what we don't know. There's a lot of inconsistencies regarding advice and knowledge. And also there's a lack of sustainable infrastructure. How do you actually find out all this? Where can you go to find out? In addition as well, there's a need for information on drug transfer to breast milk. So, after the pregnancy, obviously, if you're breastfeeding your child, the transfer of medication into breast milk, it's a vastly understudied area. There's very much not enough known. And no person should have to make an uninformed decision about breastfeeding their baby. So the ecosystem that Conception is setting up is envisioned to efficiently, systematically, and also in an ethically responsible manner generate and disseminate reliable evidence-based information regarding the effects of medication used by people who are pregnant and breastfeeding. It's very important to kind of know that this will be achieved by it's a big, very large network that will work together for this, as shown by the large amount of participants. So it's going to be a way of cataloging, linking, collecting, and analyzing data from various sources: pharmacovigilance, modeling, routine healthcare, breast milk samples, that will all add to this ecosystem of knowledge. So what will Conception do with the evidence that they're collecting? So data and evidence from Conception and from other research and literature is reviewed by teratology specialists and synthesized into knowledge. It's quality assured, generating up-to-date knowledge that will be valid for all EU countries. This knowledge is made available through an online EU drug knowledge bank, which then can be translated to local language on a national level. So, that's a really important part in terms of actually getting this information out and making it very, very accessible. The knowledge bank will increase healthcare professional and pregnant and breastfeeding people's access to reliable information. The pregnant person can look up the information themselves, or alternatively, the healthcare professional will be a lot more informed about, what is and isn't safe. And all this will lead together to that well-informed, evidence-based therapeutic choices can be made. So it's really important. One huge part of this, obviously, is to have a very solid and clear engagement with all key stakeholders. So been involvement with regulatory stakeholders, healthcare system stakeholders, and obviously women, pregnant people, families, representatives, all been kind of involved through multiple channels with the project throughout the development of the project, its existence, co-creation with the stakeholder engagements, a kind of circulation of engagement outcomes, and communicating to stakeholder what needs and concerns they have to communicate that back to the project. The project also, kind of promoting robust methods for kind of real-world evidence generation, and that will then help to kind of maximize the impact of the scientific results. So there's, a lot of engagement back and forth, but it's absolutely crucial for this to be, a properly set up and properly functioning ecosystem. So there's a lot that goes into it, but it's all very important to contribute to the final existence of this. So that's really a super quick whistle-stop tour of the Conception project. You can find more information on the website, or alternatively, you'll probably hear more about it. Or if you have any questions, you could ask it at the end of the session. Thanks so much. Over to you, Peggy.
Thank you very much, Vanessa, for that very interesting presentation. And as Vanessa said, just to remind everybody that there is a Q&A button at the bottom of your screens. So if you have any questions whatsoever, Marlene is there taking note of all the questions. So we'd be delighted to answer anything that you might want to know. Thank you very, very much. Thank you very much again, Vanessa. That was great. Thank you. And I suppose following on from Vanessa and Vanessa's presentation on conception, we're very happy to have Dr. Corinne de Vries from the European Medicines Agency. Are you there, Corinne? If you'd like to turn on your screen.
I'm here, but I can't turn on my screen because the host says stop me from sharing my screen. Oh, no, now it's working. Okay, hang on.
Oh, that's great, Corinne. You're very, very welcome, Corinne. Delighted to have you here. And just to give you a bit of a background to you yourself, Corinne heads the Office for Science and Innovation Support in the Human Medicines Research and Development Support Division at the European Medicines Agency. And so we're delighted to have you here today. And of course, the Institute has been working with the European Medicines Agency on your patient, and we're a member of the Patient and Consumer Working Group for over 10 years now. Hilden represents us, and sometimes Rebecca as well. So we're very happy to be part of your work and support the work that the EMA is doing. But Corinne, just when you were listening to Vanessa, I just have a question around, I suppose, the whole area of safety of medicines and, of course, pharmacovigilance as well. I know in your new regulatory strategy 2025, the European Medicines Agency has addressed various unmet medical needs for certain population groups, such as pregnant and breastfeeding women, which we're delighted with. And we were part of your workshop that you held 2 years ago in September, which is an excellent workshop, which really gave a very, very clear explanation of what the issues are around safety of medicines and pregnancy. And you had quite a number of experts talking about it. But you know, and we hope in the future you get the support that you need for your extended work that you're doing. But in the whole area of pharmacovigilance, how do you feel about that? And what would you like to sort of discuss in the area of pharmacovigilance and safety of medicines and pregnancy? Where do you see it going from here?
Thank you so much, and thanks for inviting me to speak at this webinar, and also for your continued reaching out to the agency and your continued support to our work on this. You mentioned pharmacovigilance, and with the recent presentation now on conception, where EMA is a consortium partner, yes, it's true, there's a lot that can be achieved there. And at the same time, in our strategy, you will have also seen that we actually are moving towards changing the focus from pharmacovigilance only to actually enriching the information on benefits and risk of medicine in pregnancy throughout the life cycle. Because what you see, for example, in the current COVID pandemic, you see that pregnant women, as has been alluded to also by Isabel, there is a hesitancy to receive vaccinations against the virus, but also when women contract COVID, especially with the Delta variant, they're more likely to become more severely ill than the people who are not pregnant, and they are less likely to receive the life-saving treatments that people who are not pregnant are receiving. And all of this is understandable because there is a hesitancy given the information gap that exists. So conception is doing a lot to address that information gap, and so is creating infrastructure for pharmacovigilance activities. And we've been able to tap into that infrastructure with the Consign project that has also been mentioned by a previous speaker. From that, we know this information gap exists. Conception is also working on development of creation of a human breast milk biobank, creation of better animal models to be translated into human understanding of transfer of medicines into the breast milk, and then uptake into the child, into the neonate when breastfed. But it's not enough. So we're really now looking at how can we, and this has also been alluded to by a previous speaker, how can we think differently about inclusion of pregnant women in clinical trials? Because if we don't, there is, at the moment, we're not generating that data in the pre-authorization phase, because there is this understandable nervousness of giving new compounds to pregnant women. And at the same time, that what we're doing is we allow our products on the market, and it very rarely is it then strictly contraindicated in pregnant women, and hence it is implicitly authorized for use in pregnant people. But then the evaluation of the use is suboptimal in my view. And conception addresses that partly, and partly, of course, you can question whether this is right. And so you see in reality that COVID, for example, pregnant women are less likely to receive the anticoagulants, the steroids. In the COVID trials, when there were treatments developed, there's a great hesitancy to offer this treatment, even as compassionate use, to pregnant women. And there are opportunities there there are real steps to be made. And so we're working together with regulators across the globe, FDA, MHRA, Japan, Saudi Arabia, to see what we can do there to achieve some change. But regulators can't do this on their own. And that's why we're so grateful also for the collaboration within Conception, where FPA partners and academia researchers are active, and clinicians, because as regulators, we can only do so much. We cannot, for example, force companies to compare their products with that of another company's when used in pregnancy. The other thing that is a real challenge, I believe, is that medicines that are used in pregnancy, most of those medicines have been on the market for decades. And for us as regulators to demand safety studies there is much more challenging than it is for some other people. And actually, even if the studies exist, companies are very hesitant to make changes, propose changes to their labeling. And at the same time, some companies will say that regulators are very hesitant to accept those proposals. And I think there's a real need for regulators, clinicians, academics, and industry and other stakeholders to come together and drive this as a concerted effort between all stakeholders who benefit. So, yeah, I hope that helps. I'm very grateful to the Conception Consortium, who will be coming to EMA to really enter into a dialogue about the infrastructure, the adverse events in pregnancy of special interest, how to generate better, how to do better signal generation and evaluation, how to get regulators to accept the novel models for breastfeeding. Yeah, and I look forward to working with you all to achieve improvements in this area. Thank you.
Thank you very, very much, Corinne, for the excellent presentation. I think it just demonstrates again how important it is that we're working together on all levels. As you say, the regulators, academia, and civil society as well, and clinicians. Thank you very, very much, Corinne. We really appreciate you coming. Thank you. I'd like to now talk to a very important organisation at a European level, without whom none of us would be here. I'm talking about, of course, the European Midwives Association. And I know Agnes is probably working, but Murphy, I hope you're still here with us, who is a past president of the European Midwives Association. Are you there, Murphy?
I am indeed. Thank you, Peggy, and many thanks for inviting me to speak. I'm sorry that Agnes can't be here, but you'll have to make up with me instead. And especially, you know, hearing such interesting speakers already, I think we have covered very good topics so far. And congratulations on your comprehensive project on the report. I think it sounds ideal, and I'm sure will be referenced widely within the midwifery community in the future.
Well, we're very grateful to you, Mervyn, because you've agreed to review the document for us. And I know it's quite a large document, but we're very grateful for you. And we need to have your input because we need to, you're one of the experts out there and people that we're working with. So we need to have your input there. So Mervyn, would you mind if I ask you a question? Just to sort of bring us all together in one sort of focus. We've learned from COVID-19 pandemic that women, and in particular pregnant women, were negatively impacted, as were the healthcare workers. So the midwife is an important partner in pregnancy. So what would you think would be improved from a policy perspective in the delivery of maternal health services to improve the service to women? And also, just as importantly, to support the work of health professionals like yourself involved in the delivery of care?
I think we can all agree that the COVID pandemic placed a real extra burden on all the health systems across Europe. And some systems were more resilient than the others, but it also highlighted the weaknesses in the current systems when looking at the maternal and child health care, especially child health from the midwifery point of view. And it's a very complex issue and complex question, really. And I'm going to just talk about very generic helicopter view about what has happened as a basis and give some ideas about how we would like the policy to support us. And I'm glad that Dr. Della Malta was here already talking about vaccination, because that's another big topic that is on our table at the moment. So EMA, as European Midwives Association, conducted a survey actually very early into the pandemic in 2020. And it was definitely clear that there was a direct impact on the changes to the delivery and practice on the antenatal, intrapartum and postnatal care. And I think the highest impact was being changes in the antenatal care and postnatally to baby and marrow diet, separation, breastfeeding, and skin to skin. So very sort of important things as regarding the relationship of information and care that midwives give to the women, not comprehensive, but as areas. For example, in a birth environment, the support for laboring women was more restricted. About 80% of the changed policies, 80% of the countries, changed policies on having birth partners present at the labor, such an important time for the women. And already about 1 in 4 did not allow any birth partners to attend the birth at all. And if we think about the different types of birth that we have, on the water immersion on those countries that it was available, actually 50% already stopped it from the day one when they changed their policy. The picture was a little bit less clear on the cesarean section and inductions of labor, if they increased or decreased because of the circumstances. But certainly we have more data on that later on. But in those days, it was maybe actually impacting more on availability of the rest of the maternity team, like the anesthetists who were deployed into other areas of the hospitals. So the access for the women to have epidurals or obstetric anesthetist being in a cesarean section was reduced, which was a major concern for the midwives regarding the safety. And it was really disappointing how few countries included midwives or multi-professional teams when developing guidelines during the pandemic. And this was reflective of prior knowledge in midwives' low visibility in clinical leadership. And finally, the level of testing and availability, actually the lack of it, PPE was highlighted, personal protective equipment was highlighted by the health professionals in most of the European countries. And this is the same with the maternity teams. And this caused a depletion on workforce delivering care and threatened their health and well-being. So we concluded that the lack of midwifery clinical leadership being absent, for example, in developing guidelines, can adversely impact in developing women and family-centered evidence-based protocols. And especially when we looked at the support of during labor and immediate postnatal period. Now, Marriott interestingly mentioned the four A's or 5 A's principle of access of care. And I mean, the time is really short, but I actually picked up interest on the availability and appropriateness to talk a little bit further about how it has impacted on us in the field, really. The pandemic alerted us to unpreparedness of the existing services. So definitely availability and appropriateness were impacted upon. Provision of antenatal care and postnatal care were severely disrupted, mainly as many countries still have hospitals as main hub for delivering care. Many hospitals cut down the face-to-face appointments, and in addition, women were reluctant and anxious in visiting hospitals. If they did so, for example, for the ultrasound scan, they could not bring their partner, and this made it women very vulnerable, and negative news on the pregnancy, for example, in any stage made information and discussion very difficult. Those countries that had a proactive approach to antenatal preparation and parent classes either had this provision shut down or did not have resources or equipment to develop alternative practices or opportunities. Now, as for labor, we have moved from majority of countries, not everywhere, but from having women alone in labor, only attended by heavily masked personnel, and for some midwives, it felt like returning to those ages. For women, there was no external interaction with others in labor, and separation of mother and baby, reducing early skin to skin, happened more often than one would have expected in the modern health systems. This also prevented some women engaging with health systems in their pregnancy and pushed them to explore other birth environments like home births, and occasionally without any health professionals to be attendants. Midwives felt very challenged in maintaining positive relationship, which is so important when looking after women throughout their childbirth, but also in labor. Postnatally, this care is very weak in Europe still. In many countries, and a pandemic further reduced the opportunity of midwives to support and advocate for women's well-being. Visits were reduced to often telephone contact only. So why was this? Why was all this sort of negative? I'm sure you are already all very versed in these negative impacts, as you mentioned earlier, but why was it on maternal health and well-being, which ripples through the family and therefore through the community and wider society? We need to ask ourselves, do the current policies support and fund maternity service care in institutions only, where the midwives, and where are the midwives in a primary care? We currently know in many countries the rural pregnant population find it very difficult and expensive to attend hospital appointments. However, midwives are ignored as an effective, skilled health professional to deliver care in a community where women live, or be part of acknowledged part of primary health care team. Continuity of care proved to be paramount for women with high-risk pregnancies if those continuity of care was provided by outreach teams or by remote health care and antenatal classes. As you know, there are improved outcomes from midwifery-led care for high-quality, safe, women-centered care. So why weren't we advocating this? Why weren't we foreseeing how the access to this midwifery-led care could be broadened before the pandemic struck? Even providing remote consultation where technology existed, so the continuity of care was more acceptable and positive experience for women. They were more likely to contact their midwife if concerned or had questions. Some women found antenatal classes actually online were their preferred option, as were more flexible, another lesson to learn. Importantly, on the other A, evidence-based guidelines and standard of care. I think there was a great initial knee-jerk reaction in many countries regarding the clinical care that was basically unacceptable for women and very questionable on the basis of human rights. As health professional, you could say it was the lack of evidence how the clinical care should be managed because of the COVID, a new situation. However, I will reiterate that the lack of multi-professional approach to the guidelines was shocking, really. Midwives are experts on their own right with the ability to develop evidence-based research guidelines. And long-term negative impact, for example, stopping breastfeeding and disrupting mother and baby diets should have changed faster than it did in all countries. Sharing data on the management and interventions has to cross the borders and quickly when crises emerge. And this impact on the information and advice, and this especially sharing and developing new information, impacts closely to women as they had to gain our trust, or we had to gain their trust, not the other way around. But the lack of information was either circled in the clinical health professional circles, and the women were very confused of hearing different health professionals giving different advice, basically, and adding to that the media. The awareness of an increase of domestic and sexual violence in society with high prevalence in pregnancy and the long-term pandemic on women's mental health exposed the lack of multi-professional and agency working and needs to be addressed in the future. This also included an interesting period in European history, well, ongoing experience in European history of our migrants and refugees. We need to understand that they are very fluid population, accessing multiple health systems, and the recent changes in the demographics of this sector of population. We had more women, we had more babies, we had more pregnancies. Continued even more concerningly, because there was no continuation of the health records or care received in different countries. And also the important issue of accessing information and need for safe abortions. So lessons learned. We always have to be positive, and I think we need to learn lessons and we need to act upon them. Capacity to act quickly and early to any emergency may give us an unexpected opening for changes that are not accessible in status quo. Opportunities may rise due to the pandemic. Opportunities rising due to the pandemic raised good practice examples, definitely for the midwives. Outreach teams, continuity of care became more important, and need for education to have effective, responsive workforce. We have been working with WHO, for example, in Romania, where midwifery education has nearly been eradicated, and the midwives were absent in community and primary care services. And now they recognize that actually midwives have an important role, and hopefully the system will recognize the role of midwives before. But before they can do it, they have to actually develop appropriate education, leadership, and challenging guidelines and the inclusion of human rights is extremely important. So including the impact of COVID in countries' socioeconomic status, recent publications like State of World's Midwifery and others spell out quite clearly that investing in midwives, improving maternal health and care will boost the communities and countries' socioeconomic status. And I think we all agree, earlier speakers already, and let's remember that the next generation sustainability. If we embrace life cycle approach and recognize the gender inequalities that still exist in Europe. We understand that every healthy pregnancy starts before a woman is even pregnant, and every postnatal period a start of the next pregnancy. So let's look at the report. I fully think that we all agree on the next steps, and we fully support the policies that will improve the women's health and women's and the, families' health across the Europe. So look forward working with you, and any questions you have, I think I can go more into detail on the topic.
Thank you very, very much, Mervy. And as Mervy said, if anybody has any questions, please put them in the Q&A at the bottom of your screen. We're happy to answer them for you. Thank you so much, Mervy. As you said, you know, the impact of COVID on pregnant women has been immense. And I think if we can learn from what's not worked and what we've learned doesn't work and address them and try and improve things, it'll be a better place for pregnant women. Just to continue on what other areas that we've covered in the report, like we were talking about health promotion, disease prevention and vaccination, etc. But we also have to look at the issues around chronic diseases and how we can prevent them. And we're very lucky and very happy to have Professor Alexandra Kowski-Willer from the University of Vienna, who's the head of the Gender and Medicine unit there, who's going to talk to us today about what the issues are around gestational diabetes. You're very, very welcome, Alexandra. Diabetes is a serious issue in pregnancy, and the complications that can arise and impact on mother and baby long-term risk factor for chronic disease in later life. How would you see gestational diabetes being prevented? What would your recommendations be, and how can they be managed effectively? Thank you, Alexandra.
Yeah, thank you, Peggy. As you have already heard, diabetes is really a major problem in pregnancy, and it's challenging both the patients and the healthcare system. It's increasing all over the world and affecting more and more younger people, and so also women at reproductive age. And as the risk factors increase, it's obesity, overweight, physical inactivity, but also older age, because you have also heard that pregnant women are getting more and more older and older. And so they have more chronic diseases like diabetes. And we have a big problem of undetected type 2 diabetes in pregnancy. And therefore, the first issue is that every woman, every pregnant woman should be tested for overt diabetes as early as possible in pregnancy, because this number is increasing. Women with undetected type 2 diabetes, diabetes first detected in pregnancy. So it should be at the first antenatal visit to find these women, because they need the same treatment as all women with pre-gestational diabetes, type 1 or type 2. This is one issue. But the bigger issue is, of course, gestational diabetes, because it affects many more women. It affects about 10% of all pregnant women in Europe. It has a big variation from 5 to more than 20%, for example, in some Asian countries. And the risk factors are, in fact, very similar, the same as for type 2 diabetes, and gestational diabetes is in reality a kind of precursor of type 2 diabetes. So every pregnant woman should be tested for gestational diabetes between 24 and 28 gestational weeks by employing an oral glucose tolerance test and use of specific criteria, specific glucose criteria for pregnancy. That's important. You have heard there is no real universal screening test for gestational diabetes, but most countries now use the criteria of the International Association of the Study Groups of Diabetes in Pregnancy, and these criteria were also adopted by the WHO in 2013. So there is some kind of consensus, at least in many European countries. But the important thing is, in fact, we could prevent at least half of all GDM cases. This has been shown by adoption of a healthy lifestyle, in reality already before pregnancy, but you even can do something in women during pregnancy. And now we know that the implementation of antenatal structured nutrition therapy and physical activity-based lifestyle interventions can help to reduce gestational weight gain and to lower the risk of gestational diabetes and to lower the risk of adverse neonatal and maternal outcomes. So what are the adverse outcomes? We have two problems. We have the perinatal outcomes, so the acute problems during pregnancy and delivery, and then we have long-term outcomes for both mother and baby. So it's really very important to interrupt this transgenerational vicious cycle of obesity and diabetes by detecting women at risk, preventing gestational diabetes, and preventing diabetes in women after gestational diabetes. So the perinatal outcomes with higher risk are preeclampsia, preterm delivery, cesarean sections, shoulder dystocia and other birth injuries, large for gestational age babies, neonatal hypoglycemia, higher risk of being admitted to intensive care units for the neonates. And for the mothers, we have we have a higher risk also of depression during pregnancy or postpartum depression. And we have a high risk of becoming, getting overt diabetes, type 2 diabetes, in the years after delivery. So the highest risk is in the first decade after delivery. And these women have a 7-fold higher risk to develop type 2 diabetes than women maintaining normal glucose tolerance during pregnancy. So it's really the group of women with the highest risk of type 2 diabetes. And it has been shown that, again, we can prevent the development of type 2 diabetes in these women by the implementation of diabetes prevention programs. This has been very clearly shown. So these women have to be tested again after pregnancy to reclassify them, their glucose tolerance, and then they all must be informed about the high risk of diabetes and possible diabetes prevention strategies. And this is always the same. It's healthy nutrition, regular exercise, at least 30 minutes daily, refraining from smoking, and weight management. So if they are overweight, they should reduce weight. If they are normal weight, they should maintain their normal weight. And again, approximately half or even more of diabetes cases following gestational diabetes could be prevented by healthy lifestyle. And this would also be a benefit not only for the women, but for the whole family, because also the children have to be monitored. They also have a higher risk to become overweight or obese later on in their life, and to develop pre-diabetes. Impaired glucose tolerance and possibly overt diabetes later on. And another thing is that all these women with gestational diabetes, with a history of gestational diabetes, they also need lifelong monitoring of all cardiovascular risk factors, not only glucose, also blood pressure, also lipids, because it was also shown that these women have a higher risk of cardiovascular disease, myocardial infarction, and stroke within the next 10-15 years after delivery, when they had gestational diabetes. So it's very important to monitor these families, the children and the mothers, and we could really do a big step forward, because diabetes is getting more and more common, it's increasing, but if we can interrupt this cycle, we could reduce diabetes in women, but we could also reduce diabetes and obesity in the next generation. And this is, I think, a very important thing. And we know what to do. It's just a problem to implement strategies at the national level, at an international level, to really reach the women and to get them to change their lifestyles. Thank you.
Thank you very, very much, Alexander. I mean, as you pointed out, pregnancy is a really good opportunity for intervention in relation to diabetes. And maybe that's something that we could be looked at in the future from a health promotion perspective as well, and disease prevention. And it's such a huge issue for preventing chronic disease in old age. With the health system's resilience being reduced and impact of COVID, I really think that this is an opportunity, and your recommendations should be able to help moving things forward.
Yeah, as you said, also COVID-19, it affects women with diabetes and gestational much more severely. So it's also important that they get vaccinated. I didn't mention this issue, but this is also a very important issue. They have a high risk of severe complications if they get COVID-19 disease. Thank you.
That's an excellent point, Alexander. Thank you so much. Thank you.
You're muted, Peggy.
Sorry, I beg your pardon. I'm very excited now to have Heidi Siller here to talk about another topic that is included in our report, and that is gender-based violence during pregnancy. And Heidi is a psychologist and works in the University of Klagenfurt in Austria, and has published and taught widely on various topics of violence and presented her work nationally and internationally. Heidi, I have a question for you. I know Gavin mentioned violence during pregnancy in relation to the National Maternity Strategy in Ireland. But gender-based violence is an issue for 1 in 3 women in the EU. The EIWH report is highlighting violence in pregnancy. This is an issue that is still tabooed. Why do you think this is? And what should we be highlighting to help pregnant women? Thank you, Heidi.
Thank you, Peggy, and thank you very much for inviting me. I'm very happy to be here at this event. I think it's such an important issue that we're talking here today. And as for your question, and as already mentioned by some previous speakers, abuse, domestic violence is also quite an issue in maternal health and for pregnant women, also during labor and postpartum. So what I would like to highlight today is actually 3 aspects. First, I would like to talk about what kind of violence are we talking about. Then also skip over to the aspect that you were asking me about potential reasons why violence is still tabooed in pregnant women. And the last point, I would like to bring these 2 together and talk about how could we best support pregnant women. What should we thinking about? So when talking about violence, it's such a diverse phenomenon, because we're talking about domestic violence, we're talking about child abuse, intimate partner violence, but also any other forms of violence that may occur in public or in private. And when we were researching midwives and how they perceived and managed violence against women, we noticed that also they perceived violence as such a diverse phenomenon, and it is a diverse phenomenon. It refers to so many different forms of violence. We heard about sexual violence and physical violence, but there's also emotional violence, coercion, psychological violence, economic violence, and also reproductive coercion that can result in pregnancy, for example. So it may happen at home, but it may be also exerted by partners or even by children. And it also may happen in institutions or in other contexts. And I think we also touched on these aspects when we're talking about maternity care and respectful maternity care. Violence may affect women during or after pregnancies, and we have a bit of inconsistencies when we're looking at the studies, because some studies show that violence may increase during pregnancy and some show that it decreases during pregnancy. So we still have to find out what are the issues here, why do we have such contradictory findings. What we do see is that many women report about violence during pregnancy in retrospect. So when the later point in the lives, when the children are already a bit older, that they report about violence happening during pregnancy or even starting or increasing during pregnancy. So we have to consider this as well. But also violent experiences in the past, so for example, during childhood may affect pregnant women. And we should consider also past experiences of violence, not only current experiences of violence. So this has 2 implications. First of all, we must consider violence experienced over a life course. And we must consider that violence has many different phases. It has many different phases and can be so diverse. So women might experience violence as a child or when growing up, in their teens or later on. And we know that such experience may resurface during pregnancy, even when the violence itself is not present anymore. So when these experiences need to be acknowledged when caring for pregnant women or during labor or even afterwards. So studies have shown that there are various triggers in pregnancy and birth that remind women about abuse in childhood, for example, or any other violent experiences in different points of their lives. It also has important health impacts on women, and these may worsen during pregnancy. So we also have to consider the interaction of violence and health, and that it might amplify health issues. Triggers that I was just referring to before may be intimate procedures, pain, for example, experienced during labor, or also a feeling of losing control or loss of control. And we heard about that in a previous presentation about respect and about giving women possibilities to participate in decision makings, for example. Or also that it's important to respect women's boundaries during labor, during examinations, and to consider that uncaring, dismissive, disrespectful behavior may serve as a trigger for women who have experienced violence or are experiencing violence in the current partnership. So it's not only triggers that may remind women of violence, but we also have to think about additional sources of violence pregnant women are facing, during labor, such as obstetric violence, so mistreatment or abuse during childbirth. And this is also one violence that needs to be considered more often when talking about violence in pregnancy. So we have to think about these forms of violence happening outside of caring for pregnant women, and also during the care of pregnant women during labor. And naturally, all these different phases of violence, they may occur in combination, so they shouldn't be talked about in isolation. What I haven't talked about now, but we have heard it in previous presentations, and I just want to briefly mention it, is that there's also not one type of woman, not one type of pregnant woman, but we have to consider all the systems and the social characteristics that may influence our vulnerability, the vulnerability of women and pregnant women, and their access to resources. And we've heard about that before, the access to maternity care, the access to midwifery care, for example, and that we have to think about that as well. So just now going to my second point, why is it still taboo? I think, and we also saw that in our research with midwives, pregnancy and childbirth are usually life events that, or periods in many women's lives that are connected to change, to a positive outlook, to nesting, to bright and sunny future, basically, kind of. And in our interviews, we also saw that midwives hesitated, and they questioned if pregnancy would actually be the right time to actually ask about violence, or if it should be better to wait until the woman herself brings it up as an important issue for herself, and that she wants to talk it, or maybe at a later time to talk about it at a later time. But what we know from research is that women prefer being asked about violence. They want to have an invitation because there's still shame, anxiety, societal taboo, and that's hugely impacting women and impedes, of course, talking freely about this issue. But it not only impedes women talking about this issue, but of course, everyone else who is taking care of the women. So it's not only us or the others, but we have to think that these taboos also affect ourselves as well. So we need to make sure that women know that it's okay to talk about it, even if it doesn't seem to be relevant, but they should be invited to talk about violence. And I think, and I believe, and also our research suggested that it's during this period of time that people would rather think about the sunny side of pregnancy and the sunny side of having a child, and less about the negative aspects. But the effects of violence is not something that suddenly stops just because someone is pregnant, or it's lifted during pregnancy. But pregnancy might also bring things up. It's a time to think about, what do I want? What do I want for my child? What do I want for in the future? What kind of parents do I want to be? And my past experiences, how would that affect me probably? So it's also a point of time where we consider things and ponder about our futures and safety, for example. And especially the sunny side that I was mentioning before, it might not be as sunny for women who have experienced violence at home or are still experiencing violence at home. So what would be the outlook? What can we take from these aspects, or from these briefly discussed aspects? First of all, midwives and all those professions caring for women during pregnancy or birth or also postpartum need to be aware about the impact of violence on women, about the diverse phases of violence, and that violence is still often quite hidden and neglected. So it's a strong necessity for us to uncover violence and to not contribute to silencing it. We also need to be aware of the danger of reenacting violence and abuse, for example, by silencing it, by not asking about it, by thinking this is not the right time now, let's not talk about it, because then we still cover up violence and we keep it hidden, basically. Other forms of reenacting violence might be not providing women with any kind of control, just not respecting her boundaries during examinations, for example. This could also, and disrespecting them in their care. So it's important to inform about intimate procedures, about what's happening, to provide room for decision-making, for example, and to avoid any kind of reenacting abuse just because we're not aware of violence and its impact on women's lives. So what I would like to sum it up, just a few bullet points, basically, what I think would be most important to do, or most important to acknowledge when thinking about violence during pregnancy. is first of all, we need to provide training to all professions dealing with women during pregnancy or labor, for example. We also need to increase awareness on a public level, but also on a professional level about the impact of violence. And we need to know more about the impact of violence also on pregnancy. We need to increase knowledge how to support self-efficacy and also control in women during, for example, labor, but also during pregnancy. But we also need to provide ongoing support for those caring for women affected by violence. And we need to consider self-help and our own well-being and own histories of violence, because these impact our how we manage violence in others as well, and how we acknowledge violence as well. We need definitely to do more research, and I think we heard that in the beginning when the maternal health report was presented, that there's still a lot of more research needs to be done. And what we've also heard is we need to connect and interact with each other in terms of working together. That's what Peggy said previously, and I like that very much. So we need to form a stronger platform, basically, to work together, to exchange knowledge, and to support each other in our doing, basically. So thank you very much, Peggy. Hand it back to you.
Thank you so much, Heidi. And you've brought up such salient points because it's the fear women have of actually reporting these incidences as well. That's number one, because of many reasons, and including the fact that she's frightened to leave, probably because of lack of financial resources. And also, as you said, that a lot of maybe the health professionals aren't aware of the red flags. They don't know how to notice them. And it's important, perhaps, another opportunity in pregnancy, that maybe that can be helped as well by what are the red flags for gender-based violence in pregnancy. Thank you so much, Heidi. The other issue is, I think, the whole issue of the impact on a woman's and children's mental health. That is huge in relation to violence. And I suppose our next speaker Our next speaker, Miriam Schooler-Osak, will help us maybe understand a bit more about that. Very happy to welcome you, Miriam, who's Professor for Intercultural Psychiatry and Psychotherapy at Charité in Berlin. And she's done extensive work in the area of women and mental health among migrants, that's just to mention one. And just to say that Miriam is the European Institute of Women's Health focal point in Germany, and we're very happy to be working with her. Miriam, I have a question for you, because Heidi's brought up issues there on gender-based violence, and there's been other issues across today in relation to maternal health. What are the issues around maternal mental health for women? And do you think that women's mental health needs are being identified and that their needs are being met currently in health system? Thank you, Miriam.
Thank you very much, Peggy, for a very kind invitation, and thank you also very much to introduce me in a very kind way. So I would like to share with you my presentation, and to start it. I had some technical problems before. I hope it will go now well. So first of all, I would like to give a short introduction to this topic, and then go on with depression, postpartum psychosis, and conclude with some recommendations. First of all, I would like to remind what is mental health, and according to WHO, it is a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. So looking to the gender differences in mental health conditions or in psychiatric illnesses, you can see that, for example, major depression is much more seen in females, and also anxiety, but also bipolar disorders. Other disorders like schizophrenia or alcoholism is much more prevalent in men. So the factors affecting mental health, Heidi mentioned gender-based violence. So all these factors are risk factors, and gender-based violence can lead to a trauma-induced or trauma-related disorder like depression or PTSD and so on. So it is a huge risk factor. Other risk factors or affecting factors are biological factors. For example, during the pregnancy, the hormone structures and so on, household change, or social or other psychosocial factors, for example, poverty, or for example, also maybe poor employment situation, or other less education and so on, but also daily stress factors. So this cumulation of everyday stress factors could also impact the mental health conditions of females. So we know that mental health conditions are much more experienced in women, but women are the one who use mental health services and medication more frequently in comparison to men. But all these daily stress factors and so on have together with, for example, work, family, and financial issues or other issues are really have really high impact on mental health conditions of females. So looking to the mental health conditions prenatal, for example, there are moderate and statistically significant higher risk of stillbirth for women with prenatal mental health conditions. And these mental health disorders are the reason for higher risk for perinatal and infant mortality. So this consists effects across a range of mental health disorders, for example, depression, anxiety, PTSD, and so on. So we need prenatal screening and access to treatment for mental health disorders, which could reduce the risk of stillbirth, perinatal, and infant mortality. Furthermore, women with a range of different mental disorders are at distinctly higher risk of delivering a preterm or low birth weight baby and of having children with poorer development outcomes. I will get back to this topic later. The underlying reasons are not fully understood, and they are likely to include a complex array of mechanisms that include direct diseases, effects, behavioral factors, but also comorbidities. For example, diabetes was mentioned, and all these factors increase the risk of pregnancy complications. So we need comprehensive support, care, and careful treatment for women with a mental health disorder if they plan a pregnancy or if they are in the process of pregnancy and postpartum situation. We need here really to focus on them regarding their mental health conditions. So, for example, depression is a mental disorder which is generally in population in a prevalence rate of 10 to 15. But women are likely to be affected twice as in comparison to men. And these depression conditions affect not only the mothers, but also the mother-infant relationship, also other relationships to fathers, to other family members, well-beings, but also the cognitive and emotional development of the infants. And we know also that children exposed to maternal depressive symptoms have poorer language skills, and this is a really bad starting point for these children, for example, regarding education or employment and so on. Furthermore, paternal depression may also occur. Having a partner with depressive symptoms can also imply less support and less involvement and during the pregnancy, and can let the pregnant woman alone. So we need therefore professional family and community support helps for the possibility to cope here. So more support and information is needed to increase the awareness and support women suffering from perinatal depression conditions. Another issue is that 1 of 5 pregnant women have been reported to be perinatal depressive. So they can develop after any pregnancy a depressive condition up to 6 months after giving the birth. And the most common occurrence seems to be 6 to 10 weeks after the delivery. So this is a very vulnerable time slot where we have to focus more on their mental health conditions. So furthermore, depression in pregnancy or following delivery may be due to a pre-existing depression mood or disorder, but it could also be a relapse or a new onset of depression. So to be aware of these issues is very important. As mentioned in a previous talk, it is very important that pre-existing depression conditions are really well treated. So we see a lot of patients who got medication interrupted suddenly because they are pregnant or they plan pregnancy. So this is not a good way to deal with these really severe mental health conditions. So we need more awareness also to medical doctors to know how to deal with medication and with pregnancy. Looking again to maternal depression with premature delivery and the lower likelihood of breastfeeding initiation is also reported in mothers with maternal depression. This disorder is really under-recognized and treatment uptake is poor. For example, women continue to experience symptoms into the postpartum time, and more than 54% of all these women with postpartum depression have actually had depression before or during the pregnancy. So if we have a screening, so we can pick them and we can get in touch with them and support them and so on. So depression and anxiety is, of course, affecting, as mentioned before, the well-being, but also the interactions in the family with baby, but it can also be treated a very good way. But we have data for the situation that women stated that they were not asked about their emotional state or mental health at the time of booking their maternity care. So this is a neglected area. So therefore, implementing screening processes and interventions aimed to reducing the psychological impact of the transition to parenthood and at improving familial well-being are needed. Another disorder which I would like to underline is postpartum psychosis. It is also called pulporal psychosis. It is really a severe mental health condition. In one of 500 mothers, it could be seen. So it is a psychiatric emergency situation. It can start suddenly days after the birth or weeks or also later, but the symptoms can vary in a big spectrum. So they can have a high mood, mania, for example. They can have also depression, as mentioned before, but also confusions, hallucinations, delusions, and so on. And in this case, we have to act very quickly, because about 1 in the 20 women may try to harm themselves or their babies. And the risk for suicide can also rise greatly for a year or longer after delivering the baby. So again, this is a very emergency situation where we have to deal in a very quick process. Appropriate detection of this postpartum psychosis is needed to increase chances that a woman will receive adequate treatment, which would help to mitigate the global disease burden and improve maternal and newborn health, but also the well-being of other members of the family. So my last slide is regarding mental health and the European Programme of Work. It's a very important and a very good program, but I think that mental health of mothers or maternal mental health should be included in this program, because there is no health without mental health. And looking to COVID-19, we know that COVID-19 has a huge impact on our mental health conditions. And I think that, for example, these vulnerable groups of pregnant women, and also together with lockdown measures and other issues, stayed at home, and they experience a lot of other risk factors during this pandemic times, and they need really to be in focus also on programs, and they need care, and they need screening processes, and of course help. So therefore there is no health without mental health. Thank you very much.
Thank you very, very much, Miriam, for that excellent presentation. Mental health is such a huge issue. As you say, COVID-19 has highlighted the issue, and particularly highlighted the issue in relation to maternal health and pregnancy as well. And I think it's something that's been discussed for a long time at a European level and with the WHO, and at national level also. And I think hopefully because of COVID, something now will be done with mental health strategies and improving mental health strategies for women, because mental health in pregnancy or depression often goes underdiagnosed or isn't even diagnosed, as you say. So I think it's a huge job ahead to do something with it.
And mental health conditions have huge impact also in comorbidities, not only on diabetes, but also in heart attack or other stroke or hypertension and so on. So there is an interaction between all these comorbidities. And if you don't treat or deal with this mental health condition, the other comorbidities get worse.
Yeah, and I suppose basically what you're saying is then we should stop working in silos, and we should bring this comprehensive approach to maternal health together, including all the topics like mental health, so that we can address them within pregnancy. Thank you so much, Miriam. Thank you so much. I just wonder, could all the panel members put on their cameras so we can see you all? Again, very much appreciated. I think we've had a very rich afternoon of presentations from the WHO on their framework, to the European Commission with vaccination and the life course approach, but maybe I suppose focusing initially on COVID. Deirdre Clune, our member of the European Parliament, who has worked so hard since we've known her over the years on the issue of health and women's health in particular. And also Gavin at a national level, very proud of the National Maternal Strategy, and that's been produced here, and the effort that was made to be inclusive and to co-create the actual plan with women themselves and all the other stakeholders that are important. Also, Vanessa, who isn't here now, she had to go to another meeting on the conception project, such an important project, I think, for pregnant women to make sure that they are safe in relation to medicines moving forward. And of course, the EMA, our regulator at a European level, who works with the stakeholders to ensure that medicines are safe moving forward as well, and is keeping in contact with all stakeholders to make sure that the consultation is there and that moving forward we can have an input, including clinicians, academics, and stakeholders can have, and civil society can have input. And down to Agnes and Murphy, what would we do without you? When, as I say, our health professionals are so important to us. And we also need to make sure that that you have an input in relation to maternal health, because you are the partners with women in maternal health care. And also Alexandra, who we've worked with for many years and who's done so much work on the issue of gender. She was the president, and is the president, sorry, of the International Gender Medicine Association, and also particularly in her relationship to diabetes, the work she's done on diabetes and gestational diabetes in particular. And Heidi, who has done such fantastic work on trying to create awareness around gender-based violence across the life course, not just in pregnancy. And it's an issue that really has to have more, be highlighted more in society in relation to health and the impact it has on women and all society's health. And Miriam as well, mental health. We cannot divide mental health from our physical health. And I think, you know, the WHO said that from the very beginning. So we need to have this comprehensive biological and also our mental health as well, that we have to work together to make sure that that we have a comprehensive approach to women's health and maternal health in particular. I'd very much like to thank all of you, the expert panelists, Deirdre Clune, our member of the European Parliament who hosted the meeting today, and to our researchers who have been so committed to this piece of research, Dr. Mairead Finn and Morgan Clark. And also, last but not least, Marlene, are you there? Would you please put on your camera? I'd like to say a very big thanks to Marlene, who is my colleague in the Institute, who has worked tremendously hard. I'm sure you all know her at this stage to organise this meeting today. Thank you so much, Marlene. We couldn't have done it without you. And thanks to Hilary as well for opening the event today, and to Tom for your usual very well managing and your patience in managing all the technology. I hope I haven't forgotten anybody. I'm delighted that all of you could make it here today, and hopefully work with all of you in the future to improve maternal health care for women and women in general over the life course. And thank you so much for taking all of this time today. It's just been a rich afternoon for me, and I hope for all our participants. And yes, thank you to the participants as well. I haven't forgotten. Thank you so much for taking the time to join here today. It's been a pleasure working with all of you this afternoon. Thank you and take care.
Peggy, thank you so much. Sorry, my video won't work. Thanks for everything.
No, thank you. Thank you.
Thanks to all the panelists as well for a great discussion.
It's fantastic. Thank you, Mairead. Thank you so much. So thank you, Corrine, Alison, Isabel, Gavin, Vanessa, Agnes and Murphy, Alexandra, Heidi, Miriam, Hilary, Marlene, and Deirdre Clune, and Tom. Thank you so much.
Thank you, Peggy.
Take care.
Thanks, Peggy. Bye. Bye-bye.
Thank you very much. Take care.
Thanks, Peggy.